Hi there, my name's Archer and I'm a final year medical student, and today we'll be going through the anatomy of the ulnar, radial and median nerve. The way we'll go through it is just by going through the origin of the nerves from the brachial plexus, their pathways in the upper limb, and then discuss what they supply in terms of musculature. And then to keep things interesting, we'll go through a little bit of clinical anatomy as well. Start off by talking about the radial nerve. So the radial nerve is a really important nerve that supplies the motor innervation to the triceps muscles as well as the extensors in the forearm and the hand. It's also got a lot of sensory innervation, innervating the arm, the forearm, as well as the lateral 3.5 digits of the fingertips. Throughout this whole presentation, if you see something written in green, it denotes motor innervation, and if it's orange, it denotes sensory innervation. In terms of the brachial plexus, it's the posterior cord of the brachial plexus that continues on, and it's got contributions all the way from C5 all the way to T1. It emerges behind the third part of the axillary artery, and around very proximally it starts to supply the medial and the long head of the triceps while still in the axilla. It also gives off a cutaneous branch known as the posterior cutaneous nerve of the arm. As it continues down, it actually descends posterolaterally through the triangular interval, as you can see on the right-hand side, and it continues down on the radial groove of the humerus. It's accompanied by the deep branch of the brachial artery, also known as the profunda brachii, and the nerve here supplies the lateral head and then also the anconeus muscle. It gives off another couple of cutaneous branches known as the lower lateral cutaneous nerve and the posterior cutaneous nerve of the forearm, and you can see the distribution there on the bottom image. Further on, it runs in the deep groove that's bordered by the brachialis, brachioradialis and extensor carpi radialis brevis as it pierces the lateral intermuscular septum. This happens around 4 fingerprints of the person above the lateral epicondyle and starts to supply the brachialis muscle as well. The radial groove then, the radial nerve, then gives off a branch to the brachioradialis, 3 finger breadths above the lateral epicondyle, and the extensor carpi radialis long as 2 finger breadths. So this is really important in terms of when we're doing any lateral incisions, working on the lateral elbow or when in surgery. As it continues on, it travels anterior to the lateral epicondyle via the cubital fossa, a really important landmark, where it starts to give off 2 branches, the deep radial nerve and the superficial radial nerve. The deep radial nerve then passes through the arcade of Frot, which is a fibrous sheath of the supinator muscle, and then becomes the posterior interosseous nerve as it's continued on. Before it does that, it actually supplies the supinator muscle itself. The posterior interosseous nerve is the main motor innervator of the extensor muscles of the forearm. It goes on distally and terminates as a ganglion and gives off some articular branches to the wrist. However, the superficial radial nerve then continues on and supplies the dorsal aspects of the lateral 3.5 digits of the hand, except for the finger tips, which are done by the median nerve, which we'll talk about later, as you can see on the bottom. Radial injuries are really interesting, and as you can imagine, the more proximal the injury, the more severe the deficit. So injuries in the axilla can result in a wrist drop, including the fingers, weakened elbow extension, and that depends on whereabouts in the axilla it is. As we spoke about before, the innervation to the triceps muscles is actually given off quite proximally. It's also going to have weakened supination due to the posterior interosseous nerve, numbness in the radial distribution, and, as we spoke about, the wrist drop. Mid-shaft humerus fractures or mid-humerus pathologies can result in wrist drops. The elbow, such as a radial tunnel syndrome, can result in a finger drop. This is because sort of the innervation to the wrist has already been given off proximally to this. It also results in a poor supination. It's important to understand that there's preserved elbow extension. There may be reduced elbow extension, but that's actually because of the pain clinically rather than the innervation. That's because of as we spoke about, the triceps muscles already being given the innervation. In terms of the wrist, when we can plaster on a bit too tight or we've got tight wristbands, we've got the cutaneous deficits in the radial distribution of the nerve. Moving on to the ulnar nerve. The ulnar nerve then comes off the medial cord of the brachial plexus and has contributions from C8 and T1. Travels medially to the axillary artery and laterally to the axillary vein in the axilla. As it travels down, it's accompanied by the brachial artery as it travels down the arm and remains medial to the coracobrachialis and the biceps brachii and brachialis muscles. It crosses to the posterior aspect of the arm and goes through the medial intermuscular septum as compared to the lateral intermuscular septum, which was the radial nerve. It runs with the superior ulnar collateral artery, and this occurs around the midpoint of the arm. The ulnar nerve then passes through this aponeurotic band between the medial head of the triceps and the medial intermuscular septum, known as the arcade of Struthers, as you can see on the right-hand side. Again, this happens roughly around 8 centimeters from the medial epicondyle. As it continues down, it continues posterior to the medial epicondyle and in the superficial condylar groove. This is known as the cubital tunnel and ulnar tunnel. This also presents as a point of pathology if there's any compression of the ulnar nerve here. When it goes through here, it gives off some articular branches to the elbow joint, and as it progresses into the forearm, it sort of ducks off and behind the two heads of the flexor carpi ulnaris muscle, as you can see on the right-hand side there. As it continues on, it gives off two major motor branches to the medial half of the flexor digitorum profundus and the flexor carpi ulnaris. Around sort of 5 centimeters before it comes off the wrist, it gives off the dorsal cutaneous branch, and you can see the distribution of that in the bottom there. And about mid-forearm, it gives off the palmar cutaneous branch of the ulnar nerve. This goes on with the ulnar artery, and it passes over the flexor retinaculum to supply the hypothena part of the palmar skin. The ulnar nerve itself, though, passes superficially over the flexor retinaculum and medially to the ulnar artery and enters the hand via the Guyon's canal, again presenting as a potential point of pathology. The nerve then terminates by giving off the superficial branch and the deep branch and happens around the pisiform bone. The superficial branch then goes on to providing the cutaneous sensation to the palmar half, the medial 1.5 digits, but also has innervation to the palmaris brevis muscle. The deep branch then continues on to supply the hypothena muscles, the medial 2 lumbricals, the adductor pollicis, and the palmar and dorsal interosseous of the hand. And again, really important for any injuries that we'll talk about in a second. So ulnar injuries can happen at any stage during the path, but I thought it'd be really important to talk about the injuries at the wrist. This can happen as it passes through the Guyon's canal, as we mentioned before, and it can happen because of trauma, fractures, dislocations, arthritis. Can also happen because of a thrombus in the ulnar artery, as we mentioned, due to the relation. And depending on whereabouts it is, you can get different clinical signs. So the zone 1 includes both motor and sensory deficits. Zone 2 is just motor, and zone 3 is just sensory. So the key sign here in terms of chronic ulnar nerve injury is the claw hand. And this is due to the lack of innervation to the 3rd and 4th lumbricals, preventing the extension of the DRP and PRP joints and preventing the flexion of the MCP joints. And this results in unopposed action of the flexor digitorum profundus and superficialis, resulting in excessive flexion of the DRP and PRPs and extension of the MCPs, as you can see on the right-hand side there. However, we also need to talk about the ulnar paradox when we talk about the ulnar nerve injuries, and this is because the more proximal the injury to the ulnar nerve, it actually results in a less imbalance of the innervation due to the flexor digitorum profundus bare muscle also being involved in a proximal injury, resulting in an injury that doesn't look as bad as what it would to a distal injury, maybe perhaps at the wrist. Moving on finally to the median nerve. The median nerve comes off the medial and lateral cords of the brachial plexus and gives off, and it has contributions all the way from C5 to T1. It travels lateral to the axillary artery in the axilla and crosses over to the medial side, of the brachial artery at, again, approximately about midpoint of the humerus. It descends medially between the biceps and triceps muscles of the arm and gains access through to the anterior side through the cubital fossa. As we all know, cubital fossa is a really important place and an important landmark for a lot of the procedures that we do, and important to know that it lies medial to the biceps brachii tendon and also the brachial artery. Interestingly, median nerve doesn't give off any branches in the arm. As it goes on, it passes through the superficial and deep heads of the pronator teres muscle proximal forearm and provides branches to the the pronator teres, the palmaris longus, the flexor digitorum superficialis, and flexor carpi radialis. As it goes on, it lies in between, basically like a sandwich between the flexor digitorum profundus deep and flexor digitorum superficialis on top. As it then comes off, gives off a really important branch known as the anterior interosseous nerve quite proximally, which then goes on to supply the flexor pollicis longus and the lateral half of the flexor digitorum profundus. As we can remember, the medial half is done by the ulnar nerve. The anterior interosseous nerve then runs along the interosseous membrane and is accompanied by the anterior interosseous artery. So as it passes through, it passes deep to the pronator quadratus muscle and also supplies this muscle as it goes on. It terminates via giving off some articular branches to the radioulnar, radiocarpal, and the carpal joints. As the median nerve continues, however, about 3 centimeters before the flexor retinaculum, it gives off this important branch known as the palmar cutaneous branch. This branch does not run in the flexor retinaculum and is not affected in the carpal tunnel syndrome, so really important to know. It pierces the deep fascia and divides into the lateral and medial branches, supplying the thenar skin and the central palmar skin respectively. So again, important, median nerve can get damaged during any time, but in the hand, it continues on in the flexor retinaculum, and we'll chat a little bit about that in a second, but it terminates by giving off the 2 branches. The really important motor branch, or the recurrent branch of the median nerve, which supplies the thenar muscles. These include the flexor pollicis brevis, the opponens pollicis, and the abductor pollicis brevis. The palmar digital branch then goes on and divides into a medial and lateral branch that supplies the 2 lateral lumbricals and the palmar surface, and the fingertips, as we mentioned earlier, about the lateral 3.5 digits. So carpal tunnel syndrome is by far the most common median nerve injury, but this was covered extensively really well by Dr. Indiana in a previous video, so I really encourage you to watch that. However, some of the other pathology that can happen is supracondylar fractures, especially in the pediatric population, that causes a proximal median nerve injury. Carpal dislocations, any sort of trauma, anterior interosseous nerve syndrome, and potential schwannomas of the median nerve. Any injuries will result in reduced sensation in the cutaneous supply, as you can see on the right-hand side there. However, I think it's really important to talk a little bit about some of the signs that you might see in median nerve injury, and one of the big ones is the hand of benediction that you can see in the proximal median nerve lesions. This happens if the lesion is actually above the anterior interosseous nerve origin, and that's because of obviously the anterior interosseous nerve being affected, the first 2 lumbricals, and the thenar muscles also being affected. This results in a lack of flexion of the first and second PRP and DIP joints due to the flexor digitorum superficialis and the profundus muscles. Also lack of flexion at the MCPs due to no innervation of the lumbricals, and the loss of thumb abduction and opposition. So when a patient tries to make a fist due to the lack of flexion, this results in this particular orientation of the hand looking a lot like the hand of benediction. And important to know, this is an active sign. So the other one is when it's a distal median nerve lesion that happens below the anterior interosseous nerve origin. And this is because of the palsy of the first and second lumbricals. So lumbricals are really important in the flexion of the MCP joints, but also really important in the extension of the interphalangeal joints. So the imbalance ends up leading to a permanent fixate, a flexion of the index and middle finger, and also very much aggravated when they're trying to extend the fingers. This is known as the median claw, and again, as we mentioned, happens when the patient tries to extend their fingers. These are my references, and thank you very much for listening.